of lecture is Main Dental Diseases. Lecturer is Dr. Mariana Lekiv. Dental problems can be troublesome, especially at night. Fortunately, most of them can be treated or prevented. Brushing and flossing, preferably twice a day, eating the right diet, and routine dental checkups are crucial steps in lightening of reasons of the patients can go along with prevention. According to the American Association, here is the list of the most experience lifetime. This lecture is devoted to these problems, and they are as follows: tooth decay, infection, gums inflammation, receding gums, halitosis, hypersensitivity of teeth, tooth wear, erosion, attrition, abrasion, oral mucosa ulcerations, tooth, dry mouth. Tooth decay. Epidemiology of dental caries. Despite advances in restorative materials and implementation of various preventive measures, more than 90% of adults experience before 30 years of age. Dental caries is a multifaceted disease involving many complex and protective factors. The clinical presentation of caries disease is a caries lesion. The severity of the disease and of individual caries lesions is a result of complex personal, biological, behavioral, and environmental factors. Some factors are protective, such as the presence of fluoride in the biofilm, whereas others lead to hard tissue destruction, such as lower. These diagrams you can see schematic representation of dental caries prevalence. It is prevalent in almost 90% of patients, and this amount of patients considers to be caries-free. And this diagram represents distribution of dental caries in humans with respect to age. So as you can see, as the age is, as the patients become older, the increase tooth decay is as well. Main reasons of dental caries, tooth decay. So on this diagram, I visualized the main component caries process. They are as follows. Bacteria appears to be the most important factor in initiating tooth decay. The most aggressive microorganisms are streptococcus. Acceptable surface where a plaque can stay for a long time not being disturbed by a toothbrush, for example, cervical areas, proximal surfaces, fish pits, so that are the places a plaque can accumulate. Microorganisms can metabolize this plaque easily. And of course, diet contributes greatly to production and development of decay. Diet that is easy digestible, carbohydrates, starches, diet that is full with candies, sweets, biscuits. By the way, constant snacking will cause accumulation of debris on the tooth surface and stagnation debris in that susceptible surfaces where plaque can hide and stay for a long time. Time, this is important that co-interacts with all that above mentioned reasons and play essential role in tooth progression, caries progression. Pay attention to this outer circle, saliva. Saliva, it is environment in which teeth taste constantly, and the properties of saliva, flow rate of saliva, function of saliva plays a great role in either caries prevention or prevention. If saliva properties is rate and function of saliva is under normal, so caries would be prevented. Opposite, if capacity is low, if there is acidic environment in our great amount of plaque, so of course it will such low buffering capacity, acidic environment will lead to caries progression. And on this diagram, you can see possible interventions that will promote prevention of tooth decay. So, such as reduce intake of cariogenic sugars, especially sucrose, will prevent from caries distribution. Avoid frequent sucrose intake, snacking, stimulate salivary sugar clearance. Reduce Streptococcus numbers by reduction in sugar intake, active or passive immunization, water and other type of fluorization, prevention during post-eruptive maturation, vicious sealing, resin solutions, restorations, plants from plaque accumulation, and as a result will prevent tooth decay. Diagrammatic representation of important role of saliva caries etiology. Under normal conditions, the tooth is continually bathed in saliva. Saliva is supersaturated with calcium phosphate ion, capable of stages of lesion formation, particularly when the fluoride ion is present. Fluoride slows down the progression of lesions. In the case of reduced salivary function, there are few factors provided by the saliva, as ability for the saliva to enhance remineralization, remove bacteria, or inhibit bacterial action. Xerostomach patients have rampant caries. Prevention strategies are timely. This diagram, you can visualize functions of saliva that maintains health of oral cavity. Most important is cleansing. It is maintained by flow rate and daily production of more liters and up to 2 liters a day. Protective function that is done by lysozyme, statins. Digestive function, taste. Saliva is responsible for taste as well, and this function is maintained by amylase, gases, and taste is responsible for zinc. Bolus formation is done due to mucins. Buffering capacity is maintained through bicarbonate, phosphate buffers. Application helps in articulation, is maintained by proline-rich glycosines that are present in saliva. And remineralization function that is done due to such ions of calcium and phosphate. Mechanism of development of tooth decay. The most generally accepted cause of dental caries is that certain bacteria in the mouth, in the presence of fermentable sugars, cause the formation of acids, which in turn decalcify teeth. Intervention in the caries process can occur at any stage, either naturally, the insertion of some procedure or treatment. Dental caries covers the continuum of atomic level demineralization through the initial enamel or region, through dentinal involvement to eventual cavitation. The dynamic balance between demineralization and remineralization determines the end result. The disease is reversible if detected early enough. since demineralization can be quantified at stages before cavitation appears. This diagram, you can see schematic representation of pathogenesis of tooth decay. So if there is a white spot lesion occurs enamel visible, the tooth suffers due to improvement hygiene, due to creation of fluorides to the expansion strategies, caries enamel can be transferred in sound enamel. And opposite, if such white spot lesion will be subjected to hygienic challenge, there will be no hygiene practices, plus there would be added of fermentable carbohydrates, great amount of organic plaque. So such caries enamel spot lesion transform to true cavity. Cavitation appear. As you can see, this is a bidirectional process, so that can be either reversed, there is improvement of hygiene practices, it can be transformed to real cavity. If there is no improvement in practices, no use of any anti-caries agents, directional process. Classification of tooth decay. For many years, caries lesions were classified according to Green-Ward classification of dental caries, which was the first introduced in 1908 and is still used today. Black's original classification consisted of 5 categories, with a 6th added later. Black's classification is based on the type of tooth affected, anterior, posterior group teeth, and the location of the lesion. Example, lingual, buccal, occlusal, palatal, etc. As you can see on the first class by Black, caries is localized on the tissues surfaces of posterior group of teeth. The second Black class, caries lesions are localized on the surface of posterior group. The third class, caries cavities are localized on the surfaces of anterior group of teeth. If it goes about fourth Black class, the lesion is localized on the surface of anterior group with involved cutting edge. The fifth class by Black is characterized by cavities that are localized on the cervical teeth. Caries lesions can be classified in different ways. Lesions can be classified as anatomical size. Thus, lesions may be in pits and fissures on smooth surfaces. Lesions may start on enamel caries, or exposed root cement to dentinal caries. Primary caries denotes lesions on restored surfaces. Lesions developing adjacent to fillings are referred to as either recurrent or secondary caries. Secondary caries occurs in areas of plaque stagnation around old fillings due to microcracks. These microcracks seen as a line of stain around a tooth-colored filling material, and microcracks that are present on the surfaces of tooth crown. Residual caries is demineralized tissue left in places before a filling was placed. Caries lesions may also be classified according to their activity. Passive lesion is described as an active lesion, whereas a lesion that may happen earlier and then stopped is referred to as an arrested inactive caries lesion. This concept of activity is very important important as it implies directly on management. Lesions require active management. Rampant caries is the name given to multiple active carious lesions that occurs in the same patient, frequently involving surfaces of teeth that are free. It may be seen in the permanent dentition of teenagers and is usually due to poor hygiene and taking frequent organic snacks and sweet drinks between meals. Pay attention to this photo of the patient undergoes rampant caries. Numerous teeth are involved, destruction of tooth crowns up to the gum line, and in that teeth that are still present, the cavity, few surfaces are involved. Main complaints of the patients in the case of tooth decay: short-term pain due to sweet and drinks. Pain stops immediately after irritant stops its diagnosis of tooth decay. A caries check is performed with the help of a light, a mirror, and a fiber optic light is often of a great assistance. A probe is a necessary tool in searching for secondary caries, together with a bite-wing crowd. It is important to remember, however, that deep caries does not automatically cause permanent damage, and other additional investigations must be taken in order to make the diagnosis. Pay attention to this picture, some of this diagram. You can see Diagnodent, laser-based tool diagnosis of hidden caries. So this device are designed to look for caries that is not visual naked eye. Basically, it is interproximal lesions in the fissures. It's prevention of tooth decay. The most important preventive roles are improving in frequency of sugar consumption. Hygiene instructions should aim to improve a reduction in the mouth. Careful flossing techniques are efficient at removing the area, even from internal. Use of fluoride containing toothpaste is of great assistance. Educational messages such as reducing the frequency of sugar intake, particularly in drinks such as tea and coffee, can have significant. The concept of hidden sugars is also very important. These sugars can be found in biscuits, crisps, and other snack foods. Removing them from the diet can aid caries reduction. Prevention of tooth decay and treatment. The main option of prevention of tooth decay is a fissure pressurizing. Fissure sealants are a preventive technique for the management of fissure lesions. They work by closing over the fissures and thus prevent the formation of plaque fissures, areas of the teeth which are difficult to keep plaque-free. In this picture you can see deep fissure, and on the picture that is below you can see fissure that is closed by sealant. An example of some sealing agent. Treatment usually is conservative and surgical, but mainly surgical approach is used in dental therapy. What does it mean? It means that caries cavity should be carefully prepared with the help of burrs and handpieces, and then restoration of some kind of restorative material should be done. Infection, pulpitis, and apical period. Caries is probably the single most important factor related to pulp and apical diseases. Before the caries actually reaches the pulp, bacterial antigens The lesion may invade the pulp's rodentinal tubules and stimulate an inflammatory reaction in the pulp. Among the diagnosed pulp diseases, symptomatic irreversible pulpitis was the most prevalent, up to 7% of pulp diseases. And patients that are involved in this disease, the patients ultimately at the age of 45 years. Most cases of apical periodontitis are associated with some form of disease. A variety of factors are implicated, which can be grouped as short-term insults, trauma, term irritation. The prevalence of periapical periodontitis is generally reported to vary according to age group. The prevalence of apical periodontitis between 7 and 86% of cases. Pay attention to this radiograph and you can see X-ray destruction of bone tissue that, and it is apical periodontitis of some kind. Classification of root canal diseases. Both pulp and pulp periodontal diseases have been subject to many classification systems with variable terminology. The most accepted in European countries are classification based American Dental Association and classification based on American Association of Endodontists. American Dental Association classification, formation of pulp tissues. So we have normal pulp, reversible pulpitis, symptomatic irreversible pulpitis, asymptomatic irreversible pulpitis, previously treated, previously initiated therapy. According to American Association of Endodontists, apical periodontitis can be classified in such way: symptomatic apical periodontitis, asymptomatic apical periodontitis, chronic apical abscess, acute apical abscess, condensing osteitis, radicular cyst. Many of the signs and symptoms overlap between the various pulp conditions due to the dynamic interactions and the progressive nature of the disease process. Therefore, the following descriptions of diseases are based on the typical presenting complaints and clinical finding. In the case of pulpitis, a chronic, long-lasting and persistent throbbing night toothache are sure signs of root infection. Referral of pain to other areas of the face, occipital area, ear, is a sign of pulp infection. Pain is triggered by hot, cold stimulus and can be managed by some kind of analgesics. In the case of apical periodontitis, both chewing and biting is painful. Pain is not calmed by analgesics. Fever and fatigue are common signs. In some cases, the area of the face around the infection becomes swelling and abscesses. In the oral cavity, swelling and abscesses is usually caused by an inflammatory process stimulated by microbial irritation, sometimes by allergic reaction or mechanical trauma. Example, biting trauma to buccal. Swelling often helps to localize the tooth, but sometimes swelling is so diffuse and extensive that additional tests are needed to find the source of the swelling. An abscess is caused by microbial irritation. It is most common in connection with acute apical periodontitis. The reaction between host defense and microbes sometimes results in the formation of a necrotic area with pus. The main components in pus are dead and living bacteria. leukocytes, and tissue remnants. If the apical abscess penetrates the cortical bone, it can be seen as a localized swelling of the mucosa, typically at the apical region of the tooth. As long as the abscess has not perforated the periosteum, the abscess is hard, while perforated abscesses are fluctuant when touched with a finger or a blunt instrument. Endodontic abscesses are far more common than periodontal abscesses, and other origins are also possible. An abscess that perforates into the oral cavity, or rarely onto the skin, forms a fistula, sinus tract. An open fistula is a sign of an acute infection. Formation of a fistula is usually followed by the disappearance of symptoms as pus and pressure are released. The most frequent cause for a fistula is apical periodontitis, but a fistula may also develop from periodontal lesions. Pay attention to these pictures, the fistula on the skin and sinus tract fistula, the apical area, the cavity. A fistula scar, this is fistula scar, may be a sign of a process that was earlier acute but was later scaled down so that the fistula was closed. However, a closed fistula does not necessarily mean a healed process. It only indicates a new type of balance between the host defense and the microbial attack in an ongoing. After root canal treatment, the fistula may also heal by scar formation. Always when a fistula is detected, a fistulograph must be taken to localize the origin of the infection. A size of 25-30 gutta-percha point is carefully inserted into the fistula with the help of tweezers, and it will usually penetrate to a depth of 10-20 millimeters. Diagnosis of root canal pathology can be done with the help of such tests. Thermal tests, the application of agents to the teeth to increase or decrease temperature and to stimulate pulp sensory responses through thermal conduction, has been the most commonly used modality for pulp testing. Pay attention, these anterior teeth are applied heated gutta-percha point, and to these anterior teeth is subjected ice in a stick. So this is a cold test and this is a hot test. If the pulp is vital, it will respond with a pain, with a sensitivity to this stimuli. Electric pulp test is one type of pulp sensibility test that can be used as an aid in the diagnosis of the status of the dental pulp. However, like thermal pulp sensibility test, it does not provide any direct information about vitality, blood supply, the pulp, or whether the pulp is necrotic. And pay attention to this picture. You can see the device, electric pulp test, electrode passive that is connected to the of the mouth, and the surface of the tooth is dried, and then the tip of the device is should touch cutting edge of the incisor, and then charity press on the button and electrical current starts its action, and if there is pain, the patient feels the pain, so he just informs the dentist about this, and the dentist record the data and then can right interpretation of the result according to the scale. X-ray. Dental X-rays are images of the teeth that uses to evaluate oral health. AC X-rays are used with low levels of radiation to capture images of teeth. This can help dentists to identify problems like cavities, tooth decay, and impacted teeth. And on this diagram is visible X-ray, and the doctor explains to the patient what is seen on the X-ray. Treatment of root canal diseases. Endodontic treatment, affected root canal, has the added purpose to maximize the possibility of completely disinfecting the root canal system and to maintain asepsis for the lifetime of the tooth. Biomechanical instrumentation in endodontics means the mechanical preparation of the root canal with due respect for the biological and anatomical features of the canal system. The primary function of the root filling is the prevention of new infection of the root canal system. Successful disinfection and effective filling of an infected pulp canal ensures success to the level achieved for vital pulp applications. Apical periodontitis may not be detected by X-ray and may persist after many treatments. The first option to eliminate this pathology is by means of pulp therapy. And this is not enough to solve the problem, endodontic surgery is chosen to solve the situation in order to eliminate the disease. Actually, on this picture is explained, you can see the process of apexectomy. And we proceed with gum diseases and periodontal infections. Gum disease affects almost half of adults in the global population. Gingivitis, marginal periodontitis, abscesses are frequent causes of discomfort. They rarely cause sharp or strong pain, but because of the great variation that patients show in their reactions to pain, the periodontal origin of symptoms must always be carefully considered. These are investigated for calculated gingivitis. Pockets are measured with a periodontal probe and evaluated from radiograph. Although fistulas more frequently originate from apical rather than marginal periodontitis. A fistula graft must always be taken to localize the origin of the sinus tract. Epidemiology of periodontal diseases. Periodontal diseases are prevalent both in developing countries and affect about 20 to 50% of global population. High prevalence of periodontal disease in adolescents, adults, and older individuals make it a public health concern. Several risk factors such as smoking, oral hygiene, diabetes mellitus, medication of some type, age, heredity, and stress are related to periodontal disease. Reasons of gum and periodontal diseases. Gum disease is caused by a buildup of plaque on the teeth. Plaque is a sticky substance that contains bacteria. Some bacteria in plaque are harmless. Some are harmful for the health of your gums. If you do not remove plaque from your teeth by brushing them, it builds up and irritates your gums. Such factors increase the risk for periodontal disease. Smoking, diabetes, poor oral hygiene, stress, heredity, teeth, underlying immunodeficiencies, for example, AIDS, fillings that have become defective, those that have hanging edges. Symptoms of gingivitis. The symptoms, the disease of gums include are bad breath, gums in pain, sore on gums, especially when chewing, red, swollen, puffy, bleeding gums. If left untreated, gingivitis can develop into periodontitis. This condition affects the tissue that support teeth, holding them in place. If periodontitis is left untreated, the bone in your jaw can break down, creating small spaces between the gums and teeth, and your teeth may become loose and fall out eventually. Periodontal disease signs and symptoms. Gums are pulling away from teeth. Teeth appear longer as gums recede. Sensitivity from hot or cold foods and drinks. Bad breath. Loose teeth that can make eating difficult. Teeth may tilt, rotate, or drift apart. Gum abscesses can develop when pus builds up around gums. And on these pictures, you can see almost all of the listed symptoms about periodontal diseases. Treatment of periodontal diseases and gum diseases. Mild cases of gum disease can usually be treated by maintaining a good level of oral hygiene. This includes brushing teeth at least twice a day, morning and night, and cleaning in between your teeth once a day at night. If you have severe gum disease, you will usually need to have further dental treatment. Professional oral hygiene and in some cases, surgery may need to be carried out. Smoking is known to make gum disease worse. Cutting down or even better cutting out cigarettes altogether will improve gum disease, as nicotine that is in the cigarettes causes destruction of blood vessels and disrupts circulation in the gum tissue. These pictures you can see the professional cleaning, the dental office with the help of toothbrush and special prophylaxis toothpaste, and removal of hard dental deposits by specialized curettes, manual hand instruments, and removal of plaque and hard dental deposits with the help of a scaler, ultrasonic scaler. The next entity that we should discuss is hypersensitivity of teeth. Dentine hypersensitivity has been defined as the pain arising from exposed dentine, typically in response to chemical, thermal, tactile, or osmotic stimuli that cannot be explained as arising from any other form of dental defect or pathology. The prevalence of dentile hypersensitivity ranges from 2.8% to 74% in different populations. The disease is prevalent in the patient with the age range of 20 till 50 years old. However, it is more prevalent in the patient with the age range of 30-40 and more prevalent in female individuals that would probably be related to their dental hygiene and dietary habits. Hypersensitive dentine is a symptom of numerous conditions: tooth wear, micro cracks, recession, etc. It can be found in any tooth, but it is most frequent in upper canines and all premolars. It is almost always on the buccal side of the tooth. The reason for dentine hypersensitivity is supposedly exposed dentine at the cervical area of the tooth, which allows irritation of the odontoblast nerve-endings complex via rapid changes in the dentinal fluid flow in the tubules. It is important to diagnose hypersensitive dentine because it often does not require endodontic treatment. but sometimes it seems like a pulpitis or inflammation of the dental pulp, very similar to this disease. So diagnosis should be done carefully and promptly. And here you have the schematic representation of hypersensitive dentine. As you can see, dentine is exposed to the oral environment. Odontoblast processes come close into dentine tubules to the surface of the dentine. In this case, any irritation, hot, cold, mastication will cause pain sensitivity to odontoblasts, and they transfer this stimuli to the pulp tissue, which reacts in a pain or sensitivity of the teeth. Signs of hypersensitivity of dentine. Hypersensitive dentine shows great individual variation in reactions to irritation. Often a blast of air to the buccal cervical area of the tooth causes a typical reaction of sharp pain lasting for up to a few seconds. Also, touching the area with an object, for example with a probe, causes pain. Sensitivity to acidic, cold, hot, and sweet foods and drinks, and pain during brushing or flossing. All of that are symptoms of hypersensitive dentine. Diagnosis of hypersensitivity of dentine. An accurate diagnosis of dentine hypersensitivity is required before initiating any treatment. The medical history will help to establish pain intensity, pain stability, and factors that exaggerate or reduce the pain. Various diagnostic methods may be employed, such as the use of a jet of air, water spray, or a probe, to elicit sensitivity of the suspect tooth. So, as you can see on these pictures, wedge-shaped defects, a loss of dentine, and gum receding, and in this way exposure of dentine to the oral environment. So these surfaces would be sensitive to above-mentioned irritants. And these pictures, you can see the check-up of air, 3-in-1 syringe, and check-in by a probe the cervical area. That areas where dentine is exposed to the oral environment and is sensitive. Management of dentine hypersensitivity. Post-diagnosis, dentine hypersensitivity is treated by below-mentioned various methods such as removal of factors contributing towards dentine hypersensitivity, correction of etiological factors like faulty tooth brushing technique, correction of problems with dentition such as premature occlusal contacts, and restricting the consumption of highly acidic foods are all important in treating dentinal hypersensitivity. Treating dentine hypersensitivity by the application of desensitizing agents. Various types of desensitizing agents are available on the dental market to relieve sensitivity. These are basically classified into two types based on the method of application. Application at home. This method is uncomplicated and rational, wherein the patient can self-apply the desensitizing agent. Some of at-home desensitizing agents are in the form of mouthwashes, chewing gums, toothpaste, and tooth powders. Application in dental clinics. Unlike home methods, this method covers fewer teeth and is more expensive. Some of the common desensitizing agents include potassium nitrate, 2% sodium fluoride oxalates, varnishes, dentine bonding agents, and composite and bioglass. These agents release their effects either by sealing the dentinal tubules or by interrupting the conduction of nerve impulses, causing the pain. Application of desensitizing agent to the dried and free from any plaque surface of the tooth surfaces in dental office, and application of bonding agents to the cervical edges of the teeth and as the cervical edges are exposed to the oral environment and sensitive. Another entity that should be discussed, it is attrition and abrasion and of course erosion. All of them are tooth wear. Attrition, abrasion, and erosion can all create a situation where enamel is gradually worn away, revealing the underlying dentine. The exposed dentinal tubules offer a potential route of invasion into the pulp for oral microbes and their products. In addition to tooth sensitivity and decay, other signs and symptoms of dental attrition include changes in tooth shape, loss of tooth structure, tooth pain, sore gums, tooth discoloration, damage to dental fillings, and restoration. Microfractures. Microfractures are defined as the fine fracture lines in dentine or enamel without the loss of hard tissue. Microfractures in dentine are a rather frequent cause of pulpal irritation. Typically, dentine microfractures cause sharp, momentary pain in the pulp as a result of occlusal activity. The mechanism for the pain is much the same as in dentine hypersensitivity. Rapid movement of dentinal fluid causes irritation of the odontoblast nerve ending complex. Pay attention to these microfractures that are visible on the anterior teeth, the facial surface. Microfractures are often totally within the tooth structure and do not extend to the surface. However, as time passes, they tend to propagate and may become exposed. Microfractures can be diagnosed by selective percussion or pressure of tooth cusps, use of fiber optics, and by direct observation of cusp cavity margins after removal of old fillings. You can see the picture. Microfractures do not necessarily cause permanent damage to the pulp. Evaluation of results from several clinical tests as well as the dental history are needed to determine whether endodontic treatment is needed. Fractures extending into the dentine always cause some irritation to the vital pulp. If the fracture is not accompanied by a continual microbial stimulus, then pulpal reactions will be mild and temporary, unless the fracture is caused by an excessive force that has also damaged pulpal circulation. Fractures that go deeper and reach the pulp always cause pulpal damage that easily becomes irreversible, unless protection of pulp is accomplished within 24 hours of the trauma. Oral cancer is the next entity that should be discussed. Mouth cancer is a serious and common dental condition that affects many people around the globe. According to the Oral Cancer Foundation, 1 person dies every hour from oral cancer in the United States, but the good news is that it can be reversed, it can be prevented and treated in the formative stages. Oral cavity cancer accounts approximately 3% of all cancers. Most of them are oral squamous cell carcinoma. And oral squamous cell carcinoma is the commonest cancer worldwide. On this diagram, you can see distribution of oral cancer. The highest percentage occupies the cancer of buccal mucosa and tongue, especially lateral borders of the tongue. The risk factors for oral cancer are alcohol use and smoking, especially chewing tobacco. Long-lasting ulceration, chronic trauma to oral mucosa are among risk factors as well. Most dental cancers start as a growth or pinkish lump in your mouth. The lower lip is the most frequent site of oral cancer overall, while the tongue is the most frequently affected site within the mouth. In the oral cavity, the majority of cancers are concentrated in the lower part of the mouth, particularly the lateral borders of the tongue, the adjacent floor of the mouth, and lingual aspect of the alveolar margin, forming a U-shaped area extending back towards the oropharynx. A 70% of oral cancers are concentrated there. This distribution may be due to the likelihood carcinogens could pool and concentrate in the lower mouth before swallowing. For the same reason, the hard palate and central dorsum of the tongue are very rarely affected. Pay attention to these pictures. Abrasive precancerous cheilitis of Manganotti of the lower lip and squamous cell carcinoma of the floor of the mouth, the condition of poor oral hygiene. Modern advances in diagnosis or screening of oral cancer. So recent clinical diagnostic tools for early detection of oral cancer include toluene chloride or toluidine blue, oral CDX brush biopsy kit, salivary diagnostics, and optical imaging systems, including goggles, special eyewear that with the help of UV light device and special filter on this eyewear will aid the dentist to visualize the early lesion of the mucosa. Healthy tissues will be light green, but diseased, affected mucosa would be darker. So these glasses. The next disease that should be discussed from the list that was mentioned at the beginning of this lecture is xerostomia or dry mouth. So dry mouth is a condition in which the salivary glands do not make enough saliva to keep the mouth wet. Dry mouth is often due to the side effect of certain medications or aging issues or as a result of radiation therapy for cancer. The oral mucosa is normally protected by saliva when it is adequate and almost in amount equality. Saliva provides lubrication, cleansing, pH buffering, antimicrobial proteins such as secretory immunoglobulins A, and aggregation and clearance of bacteria. But in the case of tobacco use, dehydration, nerve damage, side effect of some medicaments, especially hypertensive medicaments, or xerostomia could develop as a result of some underlying diseases such as Sjogren's syndrome, HIV/AIDS, Alzheimer's disease, diabetes mellitus, anemia, cystic fibrosis, rheumatoid arthritis, hypertension, Parkinson's disease, stroke, and mumps. So all of that are possible reasons of xerostomia or dry mouth, and it should be So the dental assistants and the dental nurses should be aware of such possible reasons of such symptom as dry mouth. We all need saliva to moisten and cleanse our mouth and digest food. Saliva also prevents infection by controlling bacteria and fungi in the mouth. When you do not make enough saliva, your mouth gets dry and uncomfortable. And common symptoms include sticky, dry feeling in the mouth, frequent thirst, sores in the mouth, sores or split skin at the corners of the mouth, cracked lips, dry feeling in the throat, burning or tingling sensation in the mouth and especially on the tongue, dry, red, raw tongue, problem speaking or trouble tasting, chewing and swallowing, hoarseness, dry nasal passage, sore throat, and bad breath. All of that are common symptoms of xerostomia. Treatment and management of xerostomia. First of all, it's necessary to understand that xerostomia is not a disease but a symptomatic sensation of a mouth dryness. Xerostomia management can be organized into 7 main goals: hydration, stimulation of salivary flow, saliva substitution, slow the loss of functional salivary gland tissue, prevent caries and promote mineralization, prevent soft tissue injury and infection, and improve comfort. It is necessary to advise the patient to undergo a topical fluoride application and to rinse their mouth after eating to avoid caries. Patients should be aware that xerostomia is a lifelong condition and they should maintain good oral hygiene, restricting caffeine intake, avoid alcohol-based mouthwashes, as it will irritate the oral cavity. And we proceed with halitosis. Halitosis, bad breath. Also called halitosis, it can be embarrassing and in some cases may even cause anxiety. It's no wonder that shelves are overflowing with gum, mints, mouthwashes, and other products designed to fight bad breath. But many of these products are only temporary measures because they don't address the cause of the problem. Halitosis, a bad odor from the mouth that is considered beyond a socially acceptable level. The odor can be worse in the morning or after smoking, drinking coffee, or eating certain foods, such as garlic. Halitosis can be caused by infection, caries, endoperiodontal lesions, bad oral hygiene, if particles of food are left in the mouth, their breakdown by bacteria produces sulfur compounds, chronic gastrointestinal disturbances, lung abscess, diabetic acidosis, uremia, kidney problem, liver failure, musty odor, self-medication with alcohol, diet that is high with garlic, onion eating. How to treat bad breath yourself. Gently brush your teeth and gums at least twice a day for 2 minutes. Use a fluoride toothpaste. Gently clean your tongue once a day using a tongue scraper or cleaner. Clean between your teeth with interdental brushes or floss at least once a day. Get regular dental checkups. Avoid dry mouth and adjust your diet. In conclusion, it is worth to mention that the basic knowledge of main dental diseases effectively support dentists in treatment procedures and provide aftercare control. are available on the screen. And thank you for your attention.